very much, Chair. Can you hear me there? Great. Great to be invited here today. Thanks very much to talk on concussion and head injuries on Friday the 13th. What can go wrong, I wonder? And good to meet up with some people that, from before. A little bit about me, just so that you know about the context and where I'm talking from. I'm Professor of Emergency Medicine at St. Vincent's University Hospital, which is in the catchment area for here, and for which the RDS drains into us, the whole of UCD, and a huge amount of sport, both in Gaelic football, hurling, university football, hockey, and a lot of sport in general, indoors as well. And any of those injuries tend to come our way. That's where I work, in St. Vincent's University Hospital in the emergency department, and that's my day job. My out-of-day job is looking after some of the injured players with Leinster Rugby, and they're going to be here tomorrow. I'm doing backup, which is the hard job. Sometimes the easy job is to get out, make the decision, get the player off, and then the guy in behind has to do the babysitting and trying to deal with why the player can't go back on and all the scenarios that come out of that. And there's a fantastic medical room here on site, and on international match days I'm also involved in providing care from there. I also look after a schools rugby team, and I was talking to Barry earlier and just mentioning that there was a study that I couldn't publish for ethics reasons, but we did look 2 years ago at one school senior side, and of the 27 players that played in the final, well, that were named on the team in the final, 25 of them had been through the emergency department at St. Vincent's University Hospital with rugby-related injuries. So we get plenty of exposure. And then in our spare time, me and the kids and Susie chase international rugby sides around seeking the Holy Grail, and we found it in Cape Town one day. That's the World Cup. So what I want to do is go back to the grassroots level. And put a bit of how onto the what that Chris spoke about, a little bit about the definition, but the on-field assessment, looking again at those symptoms and those early symptoms as well as some of the delayed symptoms after they come off the pitch. And again, a little bit of issue about how we deal with those in the emergency department environment and get them back to play. And some of the special considerations that we need to think about as well. And this has already been mentioned by Michael. By the way, what a fantastic place to run a concussion clinic, 9 Hope Avenue. Fantastic place, Michael. But this is this is April edition of the British Journal of Sports Medicine, which collated all the data from the Zurich conference, which was in November last year, and I certainly commend that for the content of that. 2 definitions, really. The sort of the more complex definition, and certainly sports-related concussion is very complex from a medical point of view, and you can start talking about pathology and pathophysiological processes. I guess to the guy in the street, it's more a temporary injury to the brain that can't be seen on routine x-rays, and we've heard that before about how often CTs and MRIs are not helpful, because that is, even when they're abnormal, that's a structural abnormality to the brain, and that's a significant traumatic brain injury, and it really isn't the concussion end of the functional abnormality of brains that we see in so many of our players. So concussion is really a subset of traumatic brain injury, of which the consequences that we heard about earlier from Michael are huge. So the common features are from this impulsive blow are really they're rapid and usually rapid in onset, but not with a loss of consciousness. And certainly the vast majority that we see of consciousness that we see don't have loss of consciousness, and in fact don't have amnesia as well. But it is a sort of a common thing, and it's something that we have to get over to parents and get over to coaches as well. Is that this line of, oh no, he can't be concussed, he wasn't knocked out. Or, no, look, he can remember everything, so he wasn't concussed. And for us as a learned group, I think we've got that message on board, but now we have to disseminate that. It's a hard place, the Pitchside Assessment. It's noisy, fast. People already have dilated pupils because of the flight and fright response. They want to play on no matter what their injury is. The referees, unfortunately, more and more don't stop the play for injured players. On the pitch, you might be looking over your shoulder because you might want to ensure that you're not going to get taken out next as play gets closer to you. And your player is getting up to try and run away from you. So it's very difficult. And I contrast that with the absolute controlled environment that I have in my normal working day, where I can sit the guy down and go through everything in a nice, relaxed environment. And it makes the on-field pitch assessment so much more difficult. For years, it was really easy. You just did that. And we know now that you don't do that anymore. We've come to learn a far better way of dealing with it. And we've borrowed many of those, the tools for that from life support courses, typically the Advanced Trauma Life Support course, the ABC, the Airway, Breathing, Circulation, Disability and Exposure. Now, not all of those can be done on the pitch in a cold, wet day. You don't want to be going stripping the patient to look for injuries. You've got to get the patient and get them retrieved to a warm, safe, dry environment. But certainly the ABC is something which has stood to us well. The A standing for checking that the airway is patent. And that's easy to do if you talk to your player and he talks back to you and you get a response. Then by definition he's got a patent airway, and in fact he's also breathing, which is very good. There are a number of, if you pardon the pun, no-brainers, and that's the chap who's had an obvious loss of consciousness, or the chap who's had a seizure on the pitch. We've had some this year. One of what I thought was going to be one of the worst concussions I had dealt with, a lad had a concussion on the Astro pitch in UCD, and he had a seizure on the pitch. And his initial CT scan was normal, but when he didn't return to normality within 2 hours, I repeated the scan, he had a big frontal bleed, and his MRI showed multiple brain hemorrhages. So in fact, he wasn't really a concussion, he was a significant traumatic brain injury, but he started off as what I thought was going to be that concussion. So some of these are dead easy because you take them from the field of play, they're definitely not going back, and it's really about the extrication and how you get them off. That's what's important as well. Similarly, the confused patient, the player who's got a headache and who's vomiting, who's nauseated, who's behaving abnormally, and we'll all have seen plenty of videos of those types of players. Those are the people who come off and don't go back on. One of the part of the assessment in terms of the airway and breathing, the circulation, and I guess at the professional level it's much easier now because we often have two people, and it's really, really hard for a single responder if you're looking after, as I do at weekends sometimes, for what I call the Weekend Warriors Junior Club, and run out with them, and you're the only person. And you want to try and stabilize the cervical spine, but you're conscious of that player's airway as well. So in the professional area where you have more than one responder available, somebody can take the cervical spine and immobilize that and have midline immobilization and stabilization, while the second responder can check to make sure that the airway is patent and the appropriate intervention is necessary around that area. But this is something that is important. I can think of two cases in the last couple of months, both cyclists actually, who had significant spinal injuries off their bike in the presence of head injury and traumatic brain injuries as well. One had a paraparesis, the other had multiple cervical spine fractures, both in the presence of head injuries. So when the player is unconscious and is unresponsive and is unable to account for himself, one needs to protect that cervical spine because of the potential of catastrophic injury. And we think in terms of yes, it's always Scottish rugby players seem to come to light. Tom Evans' terrible injury to his cervical spine a couple of years ago against Wales. So these are the list here you'll have read of areas where you can particularly concerned about potential cervical spine injury in terms of the mechanism. The difficult thing, of course, is that as a player, you're always watching the players and not necessarily the game, but some of these you actually miss because there's a ruck or a maul or a number of players in between you. If it's a Gaelic midfield player and he's gone in the air and your line of sight isn't correct, then you may not see the way and the mechanism in which a player has landed. And certainly I think it's going to be welcome to see more pitchside videos to replays of mechanism of injuries, so you can get a feeling and an understanding. And often I think some legs have been it's been a difficult scenario assessing players when they come off when you haven't seen the mechanism of the injury, and it's a luxury that Sky Sport and the crowds in general get to see people wobbling off, but by the time you're maybe handed a player, he's perfectly normal and you haven't seen that mechanism. So that's something we need to address going forward. taking that player off and the mechanism by which we extricate that player is crucial. Again, a Scottish player here, fantastically well cared for. I mean, I think every time I look at it, I see other things. This guy's actually even protecting. He may be holding the oxygen mask on, but he's probably protecting the dignity of the player as well by shielding him away from sort of cameras. His cervical spine is immobilized. He's got an oxygen mask. He's well strapped down. He's got a personal responder to look after his head. He's got a cervical spine immobilized with his collar. Now, and in fairness to Kilkenny hurlers or whatever, I don't know the mechanism of this, and maybe the guy was having a sleep or something, but I don't know if it was a head injury. But it just struck me that if it was, this isn't the right way to take a player off a pitch. The symptoms and signs, the earlier as you get there, headaches, dizziness, and dizziness really is probably the best symptom. The most worrying symptom of all if a player has on the field. So that's certainly one that lights my eyes up if he volunteers that he feels dizzy, or if he agrees to the questioning of being dizzy. Lack of awareness of surroundings and the player that drifts away from you and is out of control. I remember taking one player off last year. We saw nothing, but he was a tight end prop, and he was found wandering around between the inside and centre and the outside centre, looking at the stand. So it was just a come with me. When we looked back afterwards, we think maybe he had taken a knee to a head in a ruck in the previous, but he got up from that, played on, but just because of where he was and the inappropriate behaviour on the pitch meant he was somebody who was coming off directly. Some of these are early, some of them are late. We need to be aware about, knowing your own players is a really good thing too, I think. And knowing that some of your players come to you, you can then backtrack and go back and think, gosh, he's not right this week. Was there something in last week's game or the game the week before that's perhaps making him vulnerable now today, and why he's gone down today, or vulnerable around him going into the match? And these are a whole number here, the sort of emotional. I group them into the emotional and the somatic ones, and the cognitive dysfunction. And these are the symptoms that you will either ask about or indeed that they can complain of to you in the kind of a day or two afterwards. And those later the symptoms we've heard before, that again, difficulty around emotional lability. It always strikes me that when in particular as the kids and the 15s and 16-year-olds, when they're being brought in, people seem to think they're just behaving a little bit immature because they're laughing or crying because they're on a spinal board as they're being wheeled through the department, and that they wouldn't do that if they were 25. An hour or two later, they're perfect young gentlemen or young ladies, and all that sort of inappropriateness is gone. And I think that inappropriateness something is a real symptom of concussion that gets put down, unfortunately, too often to immaturity and isn't recognised as a significant, whether it be the excessive teariness or that excessive emotional lability. And then onwards, the sort of memory dysfunction, fatigability, poor academic performance, and the sleep disturbance that goes with it, are things that people need to be perceptive to. The good news, I guess, is that for the vast majority, certainly the vast majority that I see in my practice of emergencies, and we would see a great deal of people referred through off the pitch. And on that, I have to say that I think this year we're seeing an awful lot more than any other year, and I think it is a credit to people like Acquired Brain Injury Ireland and the IRFU and the International Rugby Board and the GAA in highlighting concussion. I think people are getting that message on board now. Families and coaches are getting that message, and we're seeing more. And like that, it's good to see those at the really low end, because if we're not seeing enough of low-end concussions, then there's people out there that we should be seeing that we're not seeing to assess properly. The Pitchside Concussion Assessment tool is a helpful tool for coaches, for their assessment, or for the medics related to with teams. Already Michael spoke about this, Michael O'Brien spoke about this type of tool, the variation with assessing Glasgow Coma scale and the Maddox, the on-field questions initially, but also the symptom evaluation, this 132, 22 point questions of 132. And I find this a very helpful tool going forward as well. It's even, it's a baseline assessment when they've been just concussed, but it's something if you see them a week later or 2 weeks later again, to go through it again. It's an objective, it's a scoring thing out of 132, and then you can say, oh yeah, look, objectively you're actually getting better. You're back down to only 14 now. You were 63 when you came in last week, and so on. And so there's also a cognitive assessment part to it, as well as the physical examination and the balance assessment, and the coordination, and that recall of the 5 words. So they're all helpful tools that you can assess in the dressing room environment in and around the time of injury. And there's also that tear-off advice leaflet that's available to players about and coaches and people that are going home with them about when to seek further help. And for some, it is important to go and seek further help because, rarely, thankfully, some will develop a problem and they need to be brought to centres that can deal with those problems. And they're some of the guidelines that we tell coaches and family members of injured players to watch out for: the deteriorating headache, repeated vomiting, unusual behaviour, and these symptoms coming on, because not all concussive symptoms happen immediately. There can be a delayed onset to concussive symptoms as well. So a player can be okay, take a minor hit, maybe be a little bit dysfunctional, recover very, very well, and come off the pitch and be quietly appropriate, but then afterwards on his way home starts to be sick, starts to develop symptoms. So when we get them, unfortunately, there is no blood test that we can, no specific blood test that we can do. There's some work being done on things like S100B and others, but we're not there. We're not there yet, principally because there's a really good blood-brain barrier, and proteins from a damaged brain don't get out from the brain into the blood. And short of doing lumbar punctures and getting CSF and doing some CSF analysis on concussed players, we really can't be doing that, and so we don't have a blood test. CT, MRI, usually normal, but there are some people for whom we will request imaging, and we follow the sort of the NICE guidelines, the National Institute of Clinical Excellence in the UK, and these are the sort of a list of people with concussive injuries for whom we would be imaging up front. But for so many young people, and if they're returning to sport, they may need further imaging later on if they get injuries down the road. So you're trying to limit the amount of exposure to radiation in terms of CT as possible, so that these people aren't getting multiple CTs, because so often they're normal. So something that we've tried to do, and Nicola Riles here is helping us work through this within the Emergency Department of Vincent's, is to have initially an experienced assessor. So there's a number of us who are members of or fellows of the Faculty of Sports and Exercise Medicine in Vincent's, and we try and get an experienced assessor to see the concussed patients. We're lucky to have a clinical decision unit ward, and we admit them to the clinical decision unit overnight rather than doing a scan up front. And we find that they're very well the next day. Then, in fact, they didn't need a CT scan. That because they're so well the following morning. Am I okay here? Can you hear me? Yeah. Great, thanks. So what we do the following morning then is to do a focused assessment on them, re-examine them again. We complete the SCAT-3, particularly the symptomatic lines of the SCAT-3 that's there, and we do a Montreal Cognitive Assessment, which is a 30-point scale. The vast majority of them, of course, do very well with this and are able to go home and follow up with the general practitioner. But a number we will bring back and offer to bring back and see our occupational therapist, where we do further cognitive assessment and emotional assessment. And for those that then have a serious problem, we bring in Nicola, who can do her assessment from a rehab perspective, and perhaps bring them into the National Rehab Centre for a functional program. So that's I think that's kind of one of the first sort of sports concussive type clinics, the sort of thing that Michael and others have available to in the States. But because of the volume of work that we're seeing, and Michael McDarragh, that is your brother Joe there, who's doing one of the assessments. So look, just I'm getting the move along sign. So the return to play, I think we should mention that the IRFU are going beyond the IRB. These are going to be guidelines in terms of return to play from January. They're taking it a step further. They're being even more conservative in returning to play. And so for the amateur sides, under 20s down, it'll be 23 days before return after a diagnosis of concussion, whereas the adults, it's going to be 21 days. And part of that is the return to play protocol that was elucidated by others earlier. And yeah, I like this one. It's a little bit complex, but when you get into it, it's good. It just means that if you fail, you go back a day, and you don't advance until you've cleared each day at a time. There are a number of concussion modifiers, that will affect concussion that we must be aware of when you're dealing with your players. In the early phase, the numbers, is this more concussions they've had? Have they had prolonged amnesia? Was there a concussion? These are all things that are going to mean that we're going to need to take it much more seriously. The threshold, as others have said, are they getting increasing concussions? Are they getting concussions with less forces more often? And with children and adolescents, these are developing brains. We must be more conservative and more caring of children's brains. We need to think about those patients that have a history of migraine. Is that a confounding variable when you're dealing with the patient's symptoms? Many patients who have depression play rugby as well. Are there medications, or is their depression a contributing factor to perhaps their symptoms and the return of their symptoms? The other special considerations, look, we have a big problem with having to deal with and mind the amateurs. In this country, we have a problem because doctors in training are restricted to the hospital environment in which they work at. So clubs can't get access to junior doctors to be volunteers to work on the pitch side. So unfortunately, many teams at the amateurs don't have doctors or physiotherapists available to them. And that's something that we have to work through, I think, with the Faculty of Sports Exercise Medicine and the Medical Council to work it so that we can free up junior doctors who will have some significant experience, perhaps working from emergency environments, to be able to work with players on the sidelines. Children, we've got to work through the second impact syndrome that Ben Robinson has already been mentioned, and very rare, thank God, but something that we all hope to never to have to encounter, but we have to be vigilant for. Prevention has been spoken about. I think there's a number of our organisations responsible for sport within Ireland that are doing fantastic work at getting the message across. The Safe Rugby course from the IRFU, that Shane Mooney is here, that from the IRFU, that has been pervasive, getting through to all the clubs from the professional level right down to clubs of the far street corners of the country, getting that message across. On prevention, helmets. I'm nervous about kids wearing these helmets. I've seen them, as so many people have said, leading with their heads. I've had 2 under-13s, both brothers, a year apart, with cervical spine injuries, who the mechanism was exactly the same. They led with their head and were wearing protective headgear. It protects the scalp, but it doesn't protect the brain inside. And I'm cautious and nervous that it might affect the torque and forces on the developing cervical spine. And that myth as well too, that gum shields mind your brain. They mind your teeth for sure, but not your brain. Again, the wonderful work being done from the RFU, from the Irish Rugby Football Union in particular, and we've heard that how the new concussion management guidelines were released here last Monday quite appropriately, and this wonderful acronym of STOP, Inform, Rest, Return. The IRB as well, in terms of making online available tutorials for coaches and players as well, to heighten and increase the awareness. This is my own favourite. This is my one. Please, sir, stop, inform, rest, and later return. Look, I'll leave you with that. This is as I said, the the IRFU's logo, which I certainly commend, and just some acknowledgements for the people that have been involved in getting the message across for concussion in sport in Ireland in particular, people in the medical department of the IRFU here, both present and past, and a number of my colleagues in Vincent's who are helping me try to develop this this concussion type clinic process for the injured athletes in our area. So thanks for your time.